Hi, I'm Carlos de Castro. I'm a professor of medicine at Duke University, specializing in hematologic malignancies. Today, we're going to be talking about paroxysmal nocturnal hemoglobinuria. What is PNH? PNH, as the name suggests, is paroxysmal. It comes on suddenly. It will go away suddenly. Nocturnal, meaning it occurs mostly at night or when you wake in the morning and urinate. And then the hemoglobinuria, as this slide demonstrates, where your urine turns quite dark, and on blood dipstick it'll be positive for blood, but you will not see red cells in the urine. It is actual free hemoglobin in the urine. And despite the name, only about 40% of patients present this way. Others will present with low blood counts or even blood clots. This is a very rare and unusual disease. It's acquired. This is not something you inherit. This is an acquired disorder, and it's characterized by intravascular hemolysis, that is, blood cells are breaking apart in the bloodstream, bone marrow failure with cytopenias, and that can be anything from white cells to platelets. Anemia usually goes with the hemolysis, and then thrombosis. And despite us learning more and more about what causes PNH, there's still incredible heterogeneity amongst patients, some being quite symptomatic, others being almost symptom-free. PNH is rare because it takes two events to cause it, and they can occur in either order. First, you have to get a mutation, usually in the PIG-A gene. It's very rare that it's other genes that are involved in GPI anchor synthesis. So 99.9% of cases are going to be in this gene we call the PIG-A gene. And that's because it's localized on the X chromosome. So it only takes one hit to knock it out. Women have lionized the other X chromosome, men only have one X chromosome. So it's a one-hit phenomena. And secondly, there has to be a condition that allows this mutant cell to become the dominant cell in the bone marrow. And as we'll look at later, we think this is mostly a T cell autoimmune attack on the bone marrow stem cells themselves. So this is just how the GPI anchor is synthesized. The GPI anchor is the way that some cells will attach certain proteins to their surface. And it's over a 20 gene step to manufacture this protein. The first step is encoded by the PIG-A gene. As I mentioned, this is on the X chromosome. And if you knock that out, you're going to get either partial or complete absence of any GPI anchored proteins on the surface of your blood cells. There's a lot of missing proteins that are GPI anchored. The two that are most important are the top two shown there. That is CD55 and CD59. These are proteins that will protect the red cell from complement. So whenever complement is activated, and it's always activated in our bodies at least a little bit, we get a viral infection or something else that will raise levels, and we'll see a lot more hemolysis. All these other enzymes and proteins that are listed here, we don't know if they have a true role in the pathogenesis of PNH, but they are missing on red cells and other white cells and platelets in the bloodstream. So I mentioned there's a lot of evidence that there's some second event that occurs allowing these PNH cells to become dominant. We know that PNH is associated with aplastic anemia, which is a T cell mediated attack on the bone marrow. About 20% of patients with aplastic anemia will have a low level PNH clone present, and about 40 to 60% will develop PNH later on after being treated for the aplastic anemia. So there is this association. And at least in PNH, we have found oligo-restricted T cells that seem to be more specific for attacking normal stem cells and leaving the PNH stem cell or mutant stem cell alone. So we think that's part of how this disease arises and why it's so rare. So the clinical picture of PNH, as I mentioned, is hemolysis due to complement activation. We activate complement and the red cells will lyse. These patients will get anemic and they'll feel fatigued. And that fatigue is usually out of proportion to just their anemia alone. They get the dark urine. If they continue to filter hemoglobin through their kidneys, they'll eventually get kidney damage from that. And the free hemoglobin that's released into the plasma will bind to nitric oxide and actually squelch it out of the system. And so all smooth muscles will contract to do that, and you end up with esophageal spasms. Patients will report chest pain or what they think is a heart attack or can't swallow. They'll get abdominal pain very commonly. Eventually, they'll develop pulmonary hypertension. Males will develop impotence, And as I mentioned, the fatigue is out of proportion to the anemia alone. So maybe it's due to this nitric oxide trapping. The blood clots that occur in here, and about 20% of patients will present with blood clots, and another up to 40% will eventually develop a blood clot. They occur in very unusual sites, very commonly in the GI tract. We're not clear why that is. So patients will present with Budd-Chiari syndrome or splenic vein thrombosis or mesenteric thrombosis. They can also be arterial clots. They can get dermal vein clots, another unusual sites, or even dural vein clots in the brain. So it's a very unusual clotting process these patients have, and we don't understand well what causes those clots. We do think it's likely related to complement activation. As I talk about treatment of the disease with complement inhibitors, the incidence of thrombosis has gone way down. And finally, patients can present with bone marrow failure or cytopenias, again, related to this T-cell mediated attack on the bone marrow, not to complement itself. And in some cases, it can be severe enough that we have to consider immunosuppressive therapy or even a bone marrow transplant. The diagnosis of PNH is not one that's easy. This is such a rare disease. Most doctors have never heard of it. They present to their primary care physicians with these various complaints, and they may be sent to GI doctors for these GI complaints. They may be sent to cardiologists. They may be sent to a urologist thinking, oh, they've got blood in their urine. And it takes a long time before somebody realizes, hey, they've got hemolysis going on. Let's send them to a hematologist. Even hematologists have not been aware of this disease because they just have never encountered it. So there can be a lot of delay in the time to diagnosis with these patients. Let's move on to the treatment of PNH. Now, typically in the prior to complement inhibitor age, we just supported these patients with transfusion support. Some of us would use prednisone to try and get them through the flares of disease, but we really had no good treatments for it. We now have complement inhibitors that we'll be talking about. This includes eculizumab and ravulizumab, and more recently pegcetacoplan. Bone marrow transplant was considered a possibility for these patients in terms of treating them. The problem with bone marrow transplant is you have a disease with an average life expectancy in the untreated days of 13 to 15 years. Nobody wanted to rush into a transplant where you have a 10 to 20% chance of dying from the transplant itself or complications of the transplant. So we would wait until these patients had a complication, such as a serious blood clot, and then you had the problem of they wouldn't tolerate a transplant well because they'd already clotted off most of their liver. So it was really a very difficult situation about advising of a transplant. Nowadays, it has a very limited role, mostly for those patients with bone marrow failure who don't respond to immunosuppressive therapy. And the treatment goals of these current complement inhibitors include correcting anemia, reducing symptoms such as fatigue, and reducing the risk of thrombosis, which, as I mentioned, was one of the major causes of death in this disease. So if we can cut that incidence down, these patients will live longer. Eculizumab was the first drug that we had for treating this disease. It was a monoclonal antibody against C5. It was actually developed by some cardiologists at Yale who thought that inhibiting complement would decrease heart damage during a myocardial infarction and therefore improve outcomes. Didn't work that well in their trials for that, but Pete Hillman heard about this treatment and said, do you mind if I try this on my PNH patients? And he took 11 patients who were heavily transfusion dependent. He gave them this monoclonal antibody infusion, and he came to the ASH meeting and reported that all 11 had this marked response within 1 to 2 weeks. That was just dramatic. And of course, this led now to the registration trials that we used for this. The registration, including the Triumph study, which was a phase 3 double-blind placebo-controlled trial, and Shepherd, which we lowered the entry criterion and was more of a safety study and had a broader inclusion criterion. All of these patients then, after they went on this trial, were allowed to go on a long-term extension trial where we looked at the incidence of, for example, thrombotic events, and all the patients that were on placebo were allowed to switch over to eculizumab. There is, with C5 inhibition, the risk of getting meningococcal infections. So everybody that gets this drug needs to be vaccinated against meningococcus. And we now have 2 vaccines, both the ACWY vaccine and the meningococcus B vaccine. So we recommend they get both these vaccines. That is still not 100% protective, but it really does make a big difference. C5 was picked in part because congenital absence of C5, those kids only get Neisseria infections, whereas if you start to inhibit or if you start to have deficiencies in earlier forms of complement, what we call the proximal parts of complement activation, those kids are severely immunocompromised and get any infection. So the Yale group thought this would be the safest point of attack in terms of inhibiting complement, and that's why they chose it. Patients need to be revaccinated according to guidelines, and we actually educate these patients and have them carry around a card saying, if I have any symptoms of meningitis, please start treatment right away, so they're aware of their complication risk here. So the summary of the clinical trials is shown here. If a picture tells 1,000 words, you can see here LDH, which is a marker of hemolysis, within 1 to 2 weeks dropping to near normal levels in these patients. The top bar there is those that were on placebo, and when they got the drug, their LDH went down almost immediately also. So there's a 86% reduction in hemolysis in these trials. There was a 92% reduction in thrombotic events, a 73% reduction in the need for transfusions, and all quality of life measures that we asked them to fill out their surveys and used the FACIT fatigue score on were markedly better. The adverse events were very similar to placebo. The major ones you should know about outside of the risk for meningococcus is that they can sometimes get a headache when they first start the treatment. We think that's because they get a vascular release as we release nitric oxide from the lysing red cells, and suddenly they're vasodilating and getting headaches from that. And then everything else was very uncommon, so it was just amazing. It should be noted that this does not treat PNH-associated bone marrow failure. As I mentioned, that is more of probably a T-cell mediated process. So this drug does not raise your white cells or your platelets if you have low counts. And in general, it did not completely restore hemoglobin levels in the majority of patients. So while they stopped needing transfusions, while they stopped lysing, their hemoglobin levels remained at a lower level. Most patients were asymptomatic with that level, but it was still something that we were noting as time went on here. Ravulizumab is basically long-acting eculizumab. They took the eculizumab monoclonal antibody and made some modifications to it so it had a much longer half-life. And because of that, you get a little bit higher levels that last a much longer time in the circulation. So eculizumab is given intravenously every 4 weeks as a loading dose, and then goes to every 2 weeks as a maintenance dose. Ravulizumab you gave on days 1 and 15, so 2 weeks apart, and then you go to every 8 weeks on a maintenance dosing. There is an allowance for moving the schedule up or back depending on what's happening with the patient. So for example, if they're going to a trip 1 week, no, you don't have to make them come back for that dose. You can move it up and get the dose into them so they're protected. And you really don't want to go much past the half-life, because then you get into problems of having all these PNH cells that are circulating. They start hemolyzing, usually gradually, but it's the risk of going through more hemolysis that we don't want to see. Ravulizumab had 2 studies that led to its approval, the 301 study, which was in treatment-naive patient, and the 302 study, which was in patients who were on eculizumab. These were both non-inferiority studies. Patients were randomized to ravulizumab versus eculizumab, and both studies showed that ravulizumab was non-inferior to eculizumab across all the endpoints that we measured. Now, we cannot say that one is superior to the other, but it is certainly much more convenient to get a drug every 8 weeks than it is every 2 weeks. So there are very few patients in the United States that are on eculizumab. One of the exceptions may be pregnancy, where we have data with eculizumab that it is very effective in helping pregnancy outcomes. Ravulizumab, we don't have that data, so we can't usually use that in pregnancy. Ravulizumab had a sustained C5 inhibition that was measured over the 8-week period. You still have to be aware of the risk of meningococcal infections with that. The other C5 inhibitor I just want to mention is crovalimab. Crovalimab binds to a different epitope on the C5 molecule. It was engineered using this smart technology that I don't understand well, but it apparently was used to pick the right epitope. It is recycled within the circulation, which means that you have sustained complement inhibition through a low-dose subcutaneous administration every 4 weeks. I should mention ravulizumab and eculizumab are both intravenous. Ravulizumab has actually gotten approval to have sub-Q administration. I don't know how many people are actually using that at this time. Anyways, this drug is sub-Q, given every 4 weeks. There are 3 phase 3 trials that are ongoing. Commodore was a phase 3 open label study just looking at the safety of patients who were on already on C5 inhibitors. The major endpoints for that were safety, tolerability, and looking at the pharmacokinetics and pharmacodynamics. Commodore 2 is the main registry study looking at the primary endpoints of transfusion requirements and hemolysis measured by LDH. And then Commodore 3 is the phase 3 study looking at in patients who have never seen a complement inhibitor before. As I mentioned, Commodore 2 is the main registry study. It was presented at the 2022 ASH meeting. It did meet both its primary endpoints. One of the concerns that was noticed during these studies is that if you still, these are patients who are on a C5 inhibitor, if you put that in combination with receiving crovalimib, you can get these target antibody complexes during that transition phase when you're switching, and these can lead to all sorts of side effects and problems with it. So you just have to be aware of that and monitor patients for that. And we usually use steroids for that. So crovalimib is an interesting drug. It's not clear where its role is going to be since we already have C5 inhibitors out there. One area where it's being used is there is a variant of C5 that we've seen almost exclusively in Asian patients that unfortunately leads to poor binding of the eculizumab or ravulizumab monoclonal antibody. So this drug obviously doesn't have that problem and could be used there. We're going to switch gears and talk about proximal complement inhibitors. And the reason this became important is that while we were blocking C5 on patients with PNH, it was noticed that some of these patients still had ongoing hemolysis. And it turns out that the majority of patients, their PNH cells, which used to be destroyed quickly through intravascular hemolysis in the MAC complex, were now surviving because we block C5. But the cells were being coated with C3 fragments, and C3 can lead to uptake of these cells by the reticuloendothelial system and lead to extravascular hemolysis. So some patients were having recurrence of their hemolysis, some quite significantly, and this was leading to suboptimal response, which we are estimating to be in about 10 to 20% of patients on C5 inhibitors. So this led to the cautious exploration of can we block complement at an earlier point, such as at C3 or in some of the cofactors that lead to activation of C3, and therefore not get the C3 coating on the red cells and block both intravascular and extravascular hemolysis. And the first one that came out is a drug called pegcetacoplan. This is a pegylated pentadecapeptide that targets C3, binds to it, and inhibits its cleavage. It's administered by a subcutaneous pump twice a week. They just recently got FDA approval for an on-body device that you can wear. So these patients can take this pump home, use it at home, or they can now have this on-body device that they just attach to their skin, so they don't even have to attach it to a pump, and it gives them the injection that they need. The randomized trial that led to approval of pegcetacoplan was named Pegasus. It was a phase 3 trial, multi-center, and we compared pegcetacoplan to eculizumab in PNH patients who were already on eculizumab and having this suboptimal response. That is, they had a hemoglobin less than 10.5 or were still needing transfusions. The primary endpoint of this study was a change in hemoglobin at week 16. And as you can see from the graph there, there was a clear improvement in hemoglobin levels to near normal levels when you were on the pegcetacoplan. There was a 4-week wash-in period, so you see those first 4 weeks in there where patients were on both drugs. The reason they did that is they didn't want patients to hemolyze while they were coming off one drug, so they put them on both drugs for 4 weeks. And all patients improved during that 4 weeks to hemoglobin that was close to 12. And then they were randomized in the red line to eculizumab monotherapy or to the pegcetacoplan in the blue line. And that, again, at week 16, we measured the hemoglobin levels, and the study clearly showed a superiority to those on with pegcetacoplan. Now, I mentioned this is a study in suboptimal responders to eculizumab, presumably because of this extravascular hemolysis. It was, pretty obvious that those that got back on eculizumab were going to go right back to where they were before. But this did show that pegcetacoplan as a monotherapy was quite effective. There is a separate study now, not going on in the United States, but in other countries, called PRINCE, that is looking at pegcetacoplan in patients who cannot get a C5 inhibitor. And the studies of the results from that are ongoing, but look very promising that, again, this drug is very effective as an initial therapy with hemoglobin levels that go very close to normal. The adverse events with pegcetacoplan include injection site reactions, diarrhea for the most part, which was mild, moderate, and very self-limited. It would only happen on once or twice in these patients, and no patients discontinued because of diarrhea. And then there have been reports of cases of breakthrough hemolysis, and this is probably a little bit of a concern as we're trying to understand it, realizing when we give a drug like pegcetacoplan, the proportion of red cells in the circulation that are true PNH cells goes way up. And if you get anything that activates complement, there is an amplification loop that can really rev that up, and you can overwhelm the amount of drug that you have in the system because of that, and lead probably to breakthrough hemolysis flares. This drug was FDA approved in May of 2021, and the results still look quite promising with it. The rate of thrombotic events appears to be the same as C5 inhibitors, so it looks like it is also preventing blood clots at the same rate with it. There's still the same risk of meningococcal infections that we have to be concerned about with it, and we're monitoring for those, and we've not seen any of those yet. But all these patients, again, are vaccinated against not only meningococcus, we actually recommend they be vaccinated against encapsulated organisms such as pneumococcus or Haemophilus influenza B. There are several other proximal complement inhibitors in the pipeline. Iptacopan is a factor B inhibitor. This is one of the cofactors for C3 cleavage. It is oral, which I think we're all very excited about, because now patients can take a pill and not have to get an infusion either subcutaneously or intravenously. There are 2 trials that are out there. Apply PNH is the randomized multi-center phase 3 trial looking at iptacopan monotherapy in patients who have residual anemia despite the standard of care therapy, whether that's eculizumab or ravulizumab. Again, primary co-endpoints were either hematological response, defined as either an increase from baseline by more than 2 grams per deciliter of hemoglobin without transfusions, and hematological response defined as having a hemoglobin level greater than 12 in the absence of transfusions. And again, the picture tells 1,000 words here. You see the patients in the light green line up there having their average hemoglobin rise to just above 12, whereas those on the C5 inhibitor therapy stayed at baseline of around 8 to 9. The majority of patients had clinically meaningful hemoglobin increases and hemoglobin greater than 12, and there was a higher rate of transfusion independence. And again, the same quality of life, fatigue were markedly improved compared to standard of care. Looking at a point, this is a phase 3 trial, again in treatment-naive patients who are not in the U.S., and 92% of them achieved a greater than 2 gram per deciliter increase in hemoglobins from baseline without transfusions by week 24. Almost 2/3 of them got a hemoglobin level greater than 12, and almost all of them had transfusion independence by week 24. All their secondary endpoints, as I mentioned, LDH, fatigue scores, etc., were met, and there were no episodes of breakthrough hemolysis reported with this drug. So this may be a better point of attack where we're not going to see that amplification affecting the complement blockade. The other proximal complement inhibitor that I'll mention is danicopan. It is a factor D inhibitor or another cofactor in activating C3. Alpha is the phase 3 trial that's comparing danicopan versus placebo. And this is being used as an add-on to C5 inhibitor therapy in patients with either evidence of extravascular hemolysis on C5 inhibitor therapy. The primary endpoint was, again, the change in hemoglobin by baseline to week 12. And again, you can see from the graph that patients who got put on danicopan had a marked improvement in their hemoglobin levels, going up by over 2 grams in the majority of cases. All other secondary endpoints showed danicopan to be superior as an add-on compared to placebo. So again, this looks like a very nice drug. Now the question is, could this be used as monotherapy or not? And they aren't really looking at that because the same company is developing for Vimurcapan, or ALXN 2050, which is even a more potent second generation factor D inhibitor. And so they're focusing on this drug as a monotherapy. And they have a ongoing phase 2 study looking at this. They did present an abstract at the British Society of Hematology, which again showed the average increase or mean increase in hemoglobin from baseline to week 12 went up by 3.9 grams, so even more impressive. And again, all secondary endpoints looked like they were markedly improved. There was no new safety signal with these drugs. They're all very similar. They all cause a little bit of headache when you first start, and yet everything else looks good. So all promising therapies, all oral therapies, which makes it very exciting for patients to hear that they may not have to get infusions again. There are additional complement inhibitors that are being tested out there. I've listed a few of them here. These are in various stages of clinical trials, and they're using a lot of different approaches, which are kind of exciting. There are peptide approaches. There's one that's using antisense silencing RNA to not only decrease the amount the liver's making, but then using a C5 antibody to block activation of what is made. And there's one that's considering using a gene therapy approach, which is very exciting. So all new therapies coming down the line. I think it's going to be difficult for us to figure out which one works best because there are no comparative trials at this time. But it is exciting that we have new approaches, and some of these may alleviate some of the problems we've had with suboptimal responders.